Right, okay, so today we're going to look at foot exercises, and we're going to have a little look at the evidence and some tips and advice for clinical practice. So I'm not sure how many of you listening have watched these webinars before, but quite often we tend to look at specific conditions. So we look at things like Achilles tendinopathy, plantar fasciitis or plantar fasciosis, metatarsalgia, all sorts of things, and then we go through what causes them, the etiology, the management, different treatment modalities, and so forth. But I think one of the things I tend to always mention is foot exercises, but we don't always go into that much depth. Another thing I always try and hammer home is the importance of a multidisciplinary approach, and also the fact that every patient is different, so there's never a one size fits all. So, as I said, I often mention foot exercises to be included into your management. And I think from my own personal perspective, this is probably the biggest thing that I've changed in my practice since I first qualified back in 2003. Now, when I first qualified, I'd dish out foot orthoses and I'd do a few calf stretches, and that'd probably be about it. But since working more with physios and other therapies, I guess I've seen the benefits of exercises, and I include them a lot more with the patients that I see. So I've also noticed that as kind of a side note, and I'll mention this a little bit more later on, is that somehow it gives more ownership to the patients rather than them thinking that all their improvement in their symptoms is in your hands. So by getting them to do some sort of exercise, they're kind of taking on their part of the bargain, if that kind of makes sense. So they're part of the whole management process. So today's webinar, I forgot to click on a slide here. There we go. So today's webinar is really looking at what exercises we could prescribe and what evidence is there as well. So obviously as well, I'll include a little bit about anatomy because that's always important. But we'll have a look at some of the benefits and also how we'd implement some of those as well. So while you're all fresh to this and you've all got your cups of coffee and everyone's wide awake, I'll get the fundamental boring stuff out of the way to start with. So there's a little bit of an anatomy reminder, and there's a couple of pictures I've put up there, one of the foot and one of the lower leg and the foot. And I don't know if you recognise, but the picture on the right-hand side, you can get that as a poster, and I've had that up in a clinic for years, really, and it's handy for me, but it's also handy to show the patients, especially if they come in with, I don't know, something nice and obvious, shall we say, like an Achilles tendinopathy or post-hip dysfunction or one of the bigger muscles. It's nice to get the poster out and say, right, this is the muscle, this is how it affects it, and then it kind of helps with the education as well. But I do think, and again, I'm one of these as well, I do think it's easy to get all hell bent and sort of, all the bigger muscles, and you forget about the tiny little intrinsic muscles which are within the foot and what they do as well. So in the next few slides, we're going to go into a bit more depth, quite literally, into the foot muscles. So big red letters there, don't forget the smaller muscles because they are really important. So the first layer, so we've stripped off the skin, we've got rid of the good old plantar fasciitis or plantar aponeurosis. So in the first layer we've got, and you can see on the picture here, the flexor digitorum brevis. So that's a large central muscle located immediately below the plantar aponeurosis. And the purpose of that is it flexes the second to fifth toes, and it's bordered by the abductor hallucis and the abductor digiti minimi. So you've got the bullet points on there as well. Might not be a bad idea if you can with this presentation to print these slides off. You can have them on your wall as well. So as I say, it's useful for you because it's a reminder, and I certainly need constantly reminding of the names of some of these things. But it's also, I think, interesting for patients because they don't realise quite how much is going on within the foot. They just think the foot's at the end of their body, it hurts, you fix it. But often people have got no idea how many muscles, ligaments, bones, tendons, and quite how intricate the foot is in its working. So I think sometimes a couple of pictures sort of speaks 1,000 words, really. So onto the second layer, we've got the quadros plantae. I've probably pronounced that completely wrong. That's located below the flexor digitorum brevis. It inserts into the tendon of flexor digitorum longus, and this is where the lumbricals originate as well. Okay, now on this slide we're going to the third layer. So what you can see there is the oblique head of adductor hallucis, and that joins the muscle's transverse head on the lateral side of the hallux. And then medially to the adductor hallucis are the two heads, the flexor hallucis brevis, and then deep to the tendon of flexor hallucis longus. And then there's flexor digiti minimi brevis on the lateral side there as well. So fourth layer there, last but by no means least. So we've got the dorsal and plantar interossi, and they're located between and below the metatarsal bones, and they act as antagonists. So essentially they have opposing actions. And one of the functions of these particular muscles, we think, is to help strengthen the metatarsal arch as well. So I know there's some debate on whether we have a metatarsal arch and the purpose of metdones and so on and so forth, but keeping these muscles nice and strong will certainly help if you think you've got sort of issues with those areas. So, right, okay, now we've got a little image there, which I found this, somebody sent this to me on Facebook the other day actually, and I kept it because I quite liked it. So I think it makes us think outside the box. So the picture there is things aren't always what they seem. And I can certainly say that with patients that come in with various presentations. So the deer isn't crossing the road is crossing the forest. So it's essentially another way of looking at the same thing, or looking at the same image, but it's two different angles of looking at it. And I think it's always useful to think outside the box. It's all too easy if you're in a busy clinic or you're running behind, or something you think is simple comes in and you just go with something without thinking. But also there's a lot of discussion forums at the moment, if you see on say Facebook and some of the other sort of internet forums, and it's all about overprescribing orthoses, and sometimes it seems to me like it's almost going the other way and the practice is really changing. And anyway, the reason behind this is there's a lack of good research out there. So good research that shows how orthoses, for argument's sake, really work. The evidence is obviously very, very important, but then so is clinical judgment and rational thinking as well. And I suppose my thought with all this on the talk about orthoses at the moment is not to throw the baby out with the bathwater. So there might be some bad studies out there where people might be extrapolating stuff from the evidence without looking at the bigger picture, but it doesn't necessarily mean that we shouldn't be doing it, just that we ought to be thinking about why, really. And I guess we could say the same with exercises. And when I wrote this presentation, excuse me, I was hoping to find tons and tons and tons of research papers with all sorts of different things about the smaller, the exercises for the smaller muscles in the foot, but I didn't find as much as I was hoping for. And some of the stuff I did find conflicted each other as well, which we'll come on to in a minute. So I think with all the modalities of treatment, it's a case of, obviously, it's important to use the research, but also think about clinical judgment and also the individual patient as well, because that can make a huge difference on how something works as well. So muscle weakness. Now, I've taken this slide from a presentation which I did last summer, which was about biomechanics in the elderly. So some of you may or may not have seen that, but I think it is an important point. So basically, we still live in a world where elderly patients have grown up with things like poor nutrition, or they may have been affected by conditions such as polio. So essentially, there's stuff like this which can be underlying factors as to why they might have muscle weakness in the first place. And really, this highlights the importance of taking a good history, because there could be these underlying factors which are predisposing your patient to muscular weakness. So things like childhood illnesses, so always remember to go back and ask lots of questions about that. So poor muscular repair in the elderly is associated with poorer overall repair. So there could be other stuff going on there. Muscular weakness could also be related to depression in the elderly. That's quite interesting if you look at the psychology aspect of it. And then there's the all-important diabetes. And this paper here in 2013, they found that individuals with diabetic neuropathy had increased intrinsic foot muscle deterioration, which was associated with second metatarsal phalangeal joint angle. and history of ulceration. And then obviously leading on from this is the potential to get forefoot deformity and skin breakdown as well. So really this slide is about thinking, I think when we talk about exercise, we think of these fit young sort of 20-something-year-old semi-athletes coming in that have got nothing else wrong with them apart from a minor foot problem. I say minor, might be quite major to them, but a foot problem that we're treating with exercises and foot orthoses and this, that and the other. But actually a lot of cases where foot exercises can really come into their own is with the elderly population that have got disease processes already going on. And things like diabetes. I mean, a lot of podiatrists see an awful lot of patients with type 2 diabetes who may be coming in for, I don't know, simple routine chiropody. You may not want to give them foot orthoses, and that's absolutely fine. They may not need them, but there might be something else that you can help them with in terms of prescribing exercises, which could help try and improve some of that intrinsic muscle strength. So think across the board. It's not just young people; it's old people, and I think old people, if not more so, in some instances. Right. Okay. So this here, the stuff I've got on this slide really comes from listening to the likes of Ben O'Nig, Luke Kelly even, and Kevin Kirby at various different conferences, and just sort of taking some of the stuff they've surmised. But there's been a lot of talk, a lot of research, a lot of interest, I guess, particularly in recent years, in looking at strong intrinsic muscles and the importance of that to support the arch. And I say recent years because nobody really talked about the intrinsics back when I first qualified. It seems to be something that's come in the last few years. So ankle strengthening, I haven't put the paper for that actually, but it has been found that in runners, weak plantar flexors can predispose ankle injury, and you could have the same concept to be applied for the elderly and falls prevention. So it doesn't just have to be young fit runners; it could be the elderly as well. And now something Ben O'Nig says, and I'll come back to him in a slide a bit later on, is that the smaller muscles react before the bigger ones. Now he's talking more about ankle muscles here. But if you think about it, it kind of makes sense. If you're smaller, if I don't know, you stand on unstable ground and you're going to go over on your ankle, if those small muscles kick in quickly, they're going to help stabilise the ankle joint and help you balance before your ankle's gone over and you've ended up ripping your ligaments or your lateral ankle muscles. So and from various parts of research he's done over the years, he's found that basically the small muscles kick in before the bigger ones do. So I guess the trick there is basically keeping them strong, and that's what he says. Keeping the smaller muscles strong helps to prevent injury in the larger ones. So don't neglect the smaller muscles, even though we can't remember what the names of them are half the time. Now, Kevin Kirby's some recent work that he's done looks at a new thought on an old concept. Most of us have heard of the Windlass mechanism, and for those that haven't, I've got a slide on that next. But he talks about the longitudinal arch load sharing system, and this kind of supports the importance of the intrinsic muscles too. So what he essentially says is that we think about the longitudinal arch, and we all know about the plantar fascia. It's one of the first things we learn about, and supporting the arch and so on and so forth. But he basically says there's a lot more to the arch than that, and he breaks it down into 4 layers, of which the plantar fascia is just one. So what he says is that if one element of these 4 structures fails, then the system still works. You still got your arch, and the arch still does what it's meant to do. But if one element fails, then it puts a lot more stress on the other 3 elements. So he breaks it down to the plantar fascia, the plantar intrinsics, which is what we're kind of talking about in this presentation, and then some of your bigger muscles like your post-hip, flexor digitorum longus, flexor hallucis longus, and your perineal muscles, and then the plantar ligaments as well. And what he also says, and this is contrary to what we sort of learned 15, 20 years ago, is that the arch is spring-like and that it doesn't lock. So we used to learn that as you went up onto your forefoot to push forward, the mid-tarsal joint locked, and that gave us a stable basis to propel the foot forward. What he's saying, and quite a few other academics at the moment, is that the foot doesn't simply lock into position and unlock. It goes through various degrees of stiffness, as things like your plantar fascia, plantar intrinsic, your bigger muscles there and your plantar ligaments, as they stiffen up and then they get to an optimum stiffness, which gives you your stability, and then they gradually unstiffen as well. So it's going through degrees of stiffness rather than sort of it unlocks. The essential thing about that is longitudinal load. Longitudinal arch load sharing systems, a mouthful, LALs for short. Is that if one element fails, the system will still remain there. So the medial lateral arch will still maintain its integrity, but it will increase tensile forces on the other elements there. So if we've got, for argument's sake, plantar intrinsics, which are weak, then that means our plantar fascia, the bigger muscles, the plantar ligaments are going to have to work harder. So therefore, could that be a precursor to getting stuff like plantar fasciitis? I don't know, it's only a suggestion, but it makes sense. So Windlass, just for a recap here, this is an image which you see quite commonly. So the picture on the left at the top there shows a sort of crude anatomy of your bones. Then the bottom is kind of in engineering terms. So if you imagine your hallux is a lever, as you lift that lever up, it pulls on the bit of string, or in anatomy terms, your plantar aponeurosis. So it pulls your calcaneus and your first closer together, which then slowly raises the arch. And then as you release that, it raises it down again. And that effect is what's happening with your windlass mechanism. So if anything kind of interferes with that, it means it doesn't sort of all happen as it should do. And then obviously as you go through the various stages of gait, it will alter propulsion and sort of so on and so forth. But that is the windlass in a nutshell. But there's always a but, isn't there? There's always a however. We think we've got it all worked out, and then somebody comes up with something else. So this paper came out very recently, only a few months ago, and again it's by Luke Kelly. So Luke Kelly actually was one of the advocators of the fact that the intrinsics played quite a big role in the arch, and I've seen him present alongside Kevin Kirby. But him and his colleagues recently did this piece of work and they found something a little bit different, and I don't think they necessarily intended to, but it is quite interesting. So this is taken from the abstract, and it said, recent work suggests that muscles within our feet are key to how the foot functions during bipedal walking and running. Here we show direct evidence for the significance of these foot muscles in supporting the mechanical performance of the human foot. Contrary to expectations, so in other words, they didn't expect to find this because they thought the intrinsics played quite a big role, but contrary to expectations, the intrinsic foot muscles contribute minimally to supporting the arch of the foot during walking and running. However, these muscles do influence our ability to produce forward propulsion from one stride to the next, highlighting their role in bipedal locomotion. So it's all a bit of new ground for us, really, because I sort of had it in my head that the plantar intrinsics help support the arch, and what this paper finds is that they don't really support their arch as we thought they did. But as the paper says, it does influence our ability to produce forward propulsion from one stride to the next. So I suppose if you take a step back, whether they're supporting the arch or whether they're helping with forward propulsion, they're still doing something, they're still playing quite a major role. So going back to clinical terms, when I've got my patient in front of me, for me, that's still an important reason to keep those muscles strong, even if they're not doing what we originally thought they were doing. You know, they're still there for a reason and they are doing something. So how can we keep them strong? So enough about the evidence and what we should and shouldn't be doing. I think one of the things that's been missing for me in recent years is I know I should be asking my patients to do more in the way of exercises, but what exactly are those exercises? When should we be telling patients to do them? And what's the evidence for them? And that's the bit that always seems to have been a little bit woolly. Physios are a great help with this, but often they're doing something that they've been doing for years and they can't necessarily bring out a research paper that's been written a couple of months ago and say, right, this is what we do and this is why we do it and this is the evidence. So look at the foot core system. There's been a bit of a debate about this in the literature as well, so I'm not going to go into a whole kind of debacle about it. But this is an interesting paper. It's about just over 4 years old, and it is worth a read, whether you agree with it all or not. Now, if you Google it, there are some sites which are more patient sites, really, not really clinician sites, but there are some sites that will claim that doing this exercise will cure flat feet and, the whole works. which it doesn't do. I mean, nothing cures flat feet really, but if you take it as another addition to your treatment toolbox, if you like, then it can work really well alongside other exercises or other treatments as well. So what the paper by, as I say, it's by McClure in 2014, and the reference is at the back if you want to look it up. But what essentially it says in this paper is that there's no gold standard for assessing the function of intrinsic muscles. So there isn't a sort of a magic test we can do that says, oh yes, they're strong or they're weak. So it is a little bit of guesswork and questioning that kind of goes with this. It says the arch is controlled by the local stabilizers, so the smaller muscles, and the global movers of the foot, so the bigger muscles. And what they've done in this paper is they've kind of compared it to the lumbo and pelvic core. So we know a lot about core stability and strengthening the core and stuff and exercises we do for the lower back. And I think patients are quite well aware of this as well. It seems to be known about more than feet, I guess. So they've kind of used that principle of core stability, but sort of put it within the foot. So there is some evidence that the short foot exercise can improve navicular drop, arch index balance, and chronic ankle instability. That's according to this paper, and there are a few other papers that back that up as well. So what is the exercise? Let's have a little look. Okay. So as I said, the foot exercise, the short foot exercise, so that's what it's called if you look it up. It's essentially a foot version of kind of your pelvic floor exercise. So suck it in and hold. So it's a little bit the same with this, and that's quite a good analogy to use, I think, especially if you're explaining it to female patients, because if they've had children as well, they'll know all about pelvic floor exercises. So it's kind of the same thing with this. So to quote the paper, basically, the foot is shortened by using the intrinsic muscles to pull the first metatarsal phalangeal joint towards the calcaneus as the medial longitudinal arch is elevated. As the arch raises during the exercise, it is also referred to as foot doming. So it sounds simple enough, but I would, if you're going to start prescribing this to patients, I would practice it first and watch the videos on YouTube to see how to do it before you show your patients. So it is important, one of the things it says in the paper, it is important that the patient learns to sense subtalar neutral. So you're going to have to put the foot in neutral and they're going to have to know roughly where that should be. But the foot's got to be neutral with the calcaneus and the metatarsal heads on the ground, and then the toes are neither flexed or extended. So essentially when the foot is shortened, you're only using the plantar intrinsic muscles. Now if you try doing this, this is quite hard to do, because when I first looked at the picture, I thought, oh yeah, that's easy. But then I realised I was clawing my toes and rolling my foot out and doing all sorts of things. So it is important that you're just using the intrinsics, not your flexors and your extensors, and rolling your foot to one side and whatever as well. And then you can progress this exercise as well. So if you've got little old ladies, they can do it while they're sitting, doing their knitting and watching the television. If you've got someone a little bit more stable or a little bit fitter or a bit younger, you can start them doing it sitting. Then you can progress to get them doing it when they're standing. And then when they're really good at that, you can progress and get them doing it when they're standing on one leg. So you've got an element of balance in there as well. So it is a progressive exercise that you can do there. Okay, so we've got another study here. So this study looks, again, specifically at the short foot exercise, and it's to see if a 4-week exercise programme does in fact dynamically support the medial longitudinal arch during functional tasks. Now they've looked at the effects of a 4-week programme, and they looked at navicular drop, arch height index, performance during a unilateral functional reaching manoeuvre, and the qualitative assessment of the ability to hold the arch position in single limb stance position. What they found is that, just to read the quote on the slide there, is that this study offers preliminary evidence to suggest that the short foot exercise training may have value in statically and dynamically supporting the medial lateral arch. Further research regarding the value of this exercise intervention in foot posture type or pathology-specific patient populations is warranted. So they're not saying this helps treat X, Y, and Z conditions. They're not saying if you come in with plantar fasciitis, this will fix it. They're not saying if you've got a certain foot posture, this will sort that out. They're saying more research is needed in that area. But they are saying it helps with the things that they were looking at in the paper. Now, obviously, this conflicts a bit with the 2018 paper, which Luke Kelly wrote that I quoted a couple of slides back. And that's because, I mean, they've got different methodologies and so on and so forth, and you could look into that in more depth. Also, this paper's older as well. But it could just perhaps be that something like the short foot exercise is strengthening something in a different way and not necessarily in the way that we think. So just because we think it is actually strengthening the plantar intrinsics, it may be that it's strengthening something else as well, or it's doing something in a different way. So I don't have the answer to this, but I do know I've used this exercise with patients and I do know it's helped. And I suppose when you look at foot orthoses, there's tons of research out there that kind of conflicts each other. And generally speaking, anybody that prescribes foot orthoses know they work. They know they work better for some patients than others. And I think we're all fairly accepting that they might not necessarily work in the way that we think they do. And this may well be the case with the short foot exercise. But what I haven't found is anything that suggests it's detrimental to anything, which is a good thing. But as I say, certainly from using it in private practice, I've found it really helpful when I've used it alongside other treatments as well. Just having a slurp of my coffee there. Right, okay, so this is another paper, another good new paper out of Staffordshire University. It's looking at the effect of toe flexion exercises on grip and the positive outcomes that this could have. So they've looked more specifically at the toe flexors rather than the plantar intrinsics. And they've identified that weak toe flexors can lead to the development of toe pathologies. And this is something that, we see a lot of again in the elderly. So from their abstract, exercises to improve the grip ability of the toes increased the static peak pressure on the apex of the second and third digits, as well as the percentage contact time on the metatarsals during gait. The ability to increase apical peak pressure and contact time after exercise could assist in improving forefoot stability and gait efficiency and in reducing toe pathology progression. So that's another good paper which is worth a read, especially if you're seeing a lot of elderly patients who you wouldn't necessarily want to be prescribing orthoses for, but you might want to do something a bit more than you're doing at the moment. So what exercise did they use? So as I said, they looked specifically at toe grip. And that's literally just getting the patient to grip something. In this particular study, they used a ball or a softball. But you're getting your patient to grip a ball with their toes and then getting them, or as I say, what they did in this paper was getting your patient to hold that grip for between 5 and 10 seconds each time. And then they ask their patients to repeat that for 5 minutes a day. So this is a really simple exercise, and you can set this for elderly patients. And it could improve their forefoot stability, gait efficiency, and reduce the progression of toe pathology, according to that paper. So something very simple you can do sitting down, reading a book. Doesn't necessarily have to be a ball. Some of the other exercises that I've used for toe grip are on here. So we've got towel curls, where with a small towel you get your patient to grip. Also picking up marbles. Toe pulls, which is in the bottom left corner there, is a little bit trickier. I've tried that and find that hard to do, but then you're working a different muscle group there. But certainly the softball, which we saw on the previous slide, the toe curls and the marble pickup, you could do a combination of those. And again, especially elderly patients, they can work really well for. So the image there, I haven't taken from a specific piece of research, but as I say, it's just what I've been using in clinical practice, and I find it quite easy. I think the importance here is making sure your patient's doing it properly. So when they grip, be it the marble, be it the softball, or be it the towel, when they grip is that they hold it and maintain that stress, if you like, on their muscles for at least 5 to 10 seconds. A lot of people will go away and they'll go scrunch, 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 so I've done my exercises, but actually the importance is slowly gripping and then holding and then slowly releasing. And if they're doing that properly, they will find that their foot aches a little bit afterwards because they've worked those muscles. And then regarding how many times you repeat it and how many times a day, I think it depends, again, on your patient. So how active they are, what their muscle strength is. So you've almost got to get them to do a few to see how they get on with it, to then assess what your benchmark's going to be or what you're going to get them to work towards. So, and that's really why on none of these slides I've put a guide for the amount of time you're meant to do it for, how long you're meant to do it for, because obviously you progress with that depending on your patient. Right, this is another paper, and I only found this the other day when I was having a little search, which is quite interesting. So it's published in the Journal of Science and Sports Medicine, and it looks more specifically at patellofemoral pain management with foot exercises and foot orthoses. So we're moving out the realms of the foot here and going up the leg. So what they found is the addition of foot-targeted exercises and foot orthoses for 12 weeks was more effective than knee-targeted exercises alone in individuals with patellofemoral pain. And the effect was apparent after 4 months, but not significantly different after 12 months. Now, for some reason, I couldn't open this paper and read it all properly, so I can't tell you if there was problems with the methodology. I also can't tell you if it was the foot orthoses or whether it was the exercises. But I guess, again, taking a step back, it's another example of doing two things together works more effectively than just doing one thing, just doing one lot of exercises on its own. Now, the image I did manage to get out the paper here, as I said, I couldn't find a full description of the exercises that they did, but I did manage to get these images. So on the far right, you can see they've got the short foot exercise, which is the one we've already discussed for the plantar intrinsics. We've also got one going up onto tiptoes, and the wobble board one there, and the strengthening with the TheraBand. But as I say, you'll have to try and look the paper up to see how long they sort of did that for, and so on and so forth. Now, I guess what you could argue is if they're doing wobble board exercises and balance and proprioception, then that's probably going to have a direct effect on the knee anyway. So, but I just thought it was quite a nice paper that shows a positive effect of doing foot exercises, and it just gave you an example of some of the exercises that they used. So, and I'm a great advocate of wobble boards as well, on people that can balance on them. Again, not your 90-year-old little person or a little old man or lady who's never used one before. But certainly people with ankle instability, or when you want to sort of strengthen the smaller muscles or improve that proprioception as well. I've had some really good results with that. And if they haven't got a wobble board, they don't want to buy one. You can get the same kind of effect with them balancing on a plump cushion in their lounge. But again, think about health and safety and make sure they've got something to grab hold of if they do fall off a bit. But yeah, balance is a really good one. So any of those you could implement into your practice. Right, so I'm coming back to Benno Nig again here, and I mentioned him earlier with our strong ankle joint. Now, I've not listed all his papers and books, but he's worth a read, and these points here come out of a presentation I saw him deliver a couple of years ago, and he basically brings forward various pieces of research which have been carried out over nearly 5 decades. I think he's been carrying out this kind of stuff. But one of his main take-home points is to focus on a strong ankle joint. Now, I've heard debates before between physios and podiatrists and various other health professionals of should we be concentrating on the core or should we be stabilising from the foot up? So kind of that whole hip down, foot up debate. I guess I've always thought you want a bit of one and a bit of the other. I don't think you should ever be cancelling out one aspect of it because I think everything kind of works together. But what Benno Nig said very, very bluntly is forget the core. What you want to focus on is the smaller muscles across the ankle joint because these react faster than the larger ones. And strong small muscles increase stability and decrease pain and injury likelihood. Now, I mentioned that word for word before in the presentation, but it does make a lot of sense. And the picture I put to the right is a big skyscraper. I don't think it's the Burj Khalifa. I can't remember which one it is. It's just an image I've got off Google somewhere. But Benno Nig in his presentation used a similar image, and he said, you know, if you were architects and you were going to stabilise this skyscraper, where would you want the most stability? And first of all, he sort of pointed at the top, and of course you don't want it at the top. Then he said, what about in the middle? Because this is where we do it if it was the core, and well, you wouldn't really want it in the middle. And then he put the arrows down at the bottom, and of course everybody agreed and said, you know, yes, of course, definitely. You want your stability at the bottom to support something which was so tall. And then he used that analogy to explain why it's so important that your ankle joints or the smaller muscles around your ankle joint are so strong. Now, you could argue that a skyscraper doesn't run, walk, leap, do any form of gait. It doesn't bend in the middle and doesn't do anything else, and I get that. But I still think the fact that strong muscles in the ankle joint are a very, very important part of what we do, and it certainly shouldn't be overlooked. But as I say, if you want to know more about that, then look up Ben Nick and look up some of his research papers, because they do make a very interesting read, and he's got some good books as well. Right, stepping back and going a bit more generalised now, and I have used this slide before as well, just to sort of hammer home a bit. But don't forget the importance of regular exercise and its importance of not only advising patients for how important it is, but convincing your patient to actually take it on board. So a paper there, 2011, conducted trials on gait efficiency and gait improvement to analyse efficiency on activity and participation in 47 adults over 12 weeks. And they found even with light basic treadmill exercise, so just walking, it improved, and participant outcomes were improved. So we're not just looking at specific things here. I mean, obviously, when people come to see us, they're coming with something specific. But I mean, this benefits all parts of the body as well. So it's your cardiovascular system, your respiratory system, so all systems that are involved with basic fitness. And then a study written last year in the British Medical Journal found that increased walking pace is beneficial. So you don't have to get patients to walk further or for longer, but if they pick up the pace and walk faster, then that has all sorts of benefits, again, on cardiovascular, respiratory systems, and so on and so forth. So even if you can't get your patients to sit still for 5 or 10 minutes a day and squash a ball between their toes or do short foot exercises or anything else, simply getting them out and simply getting them to do a short walk at a reasonable pace as often as they can have all sorts of effects as well, positive, beneficial effects. So, and I guess we are health professionals, so we should be promoting the sort of that healthy side of it as well. So, right, psychology. Now, this is something which I've noticed along the way, rather than anything specific that I've read anywhere. But what I have noticed is that the more you engage your patient with their recovery management, the more compliant they tend to be. So I guess in a way, it's a little bit like empowering them to take ownership. And that doesn't just stretch to doing exercises. It could go, you could go into the whole realms of healthy eating, lifestyle, and so on and so forth. But I do find if you say, right, this is what I'm going to do, and so I'll use the example of foot orthoses, I guess, because that's more my remit. But if you explain to your patient, this is the problem, this is what's causing it, this is what I'm going to do to help you, and this is how, and this is what you need to do, and they just generally tended to be more compliant. Whereas when I first started out, I tended to find I had patients that came in, they sort of dumped their problems onto you, and then it's kind of up to you to sort it out. And all they have to do is wear whatever orthotic or anything you put in your shoe. So this does, I think, giving them exercises does somehow involve them more in their management and helps them take ownership. So, just a little side note that I've noticed. Now, if you do need a little bit of help with this, obviously you can go back and rewatch the webinar. It will be on YouTube later. Also, you can pause it on YouTube as well if you want to spend longer looking at one slide or another, or if you want to take an image from it or so on. But if you do want a little bit of help, at LBG Medical, we have come up with a new foot exercise leaflet. It's only 2 or 3 sides, I think it is, or 1, 2, yeah, about 4 or 5 sides. It's not War and Peace, and you might want to take things out, cross things off, or add bits in. But essentially, it's just a gentle reminder to patients to do their part. The one thing I would say is if you do recommend any or all of the exercises on the leaflet, do go through them with your patient and get your patient to demonstrate them back to make sure they're performing it correctly. Also remember, it's a guide, and sort of the clue there is in the title, a guide to foot exercises. So they're not rules set in stone, and there's suggestions I think we put on there for how long you want to hold exercises for, but they are just suggestions. So different patients will have different abilities, so again, there isn't a one size fits all. But I do find it's handy once you explain something to a patient to give them some sort of something, I don't know, like a piece of paper or whatever with the exercises written on, because it helps as a reminder, because often they remember it all when they're in clinic, and as soon as they get home they forget. And if they've got it on the side at home, it helps remind them to do the exercises as well. So it's a little bit of a sort of push in the right direction. So we've got the short foot exercise on there, we've got the toe curling, we've got the balancing, and we've got the rolling the ball under the foot as well. But as I said, you could add more to that if you wanted to. So that just about brings us to time. So I guess the conclusion, always think about the bigger picture. Always think about what else you could be doing. I've used this analogy before as well, but somebody once said to me that your management for your patient that comes in with their condition is a bit like a recipe to a cake. So you don't just give them the butter or the sugar, but you give them a combination of different things, and that whole combination, which essentially the ingredients make your cake, the whole combination of management, be it exercises, orthoses, stretching, anti-inflammatories, whatever else you prescribe, all of that is the bigger picture. That's what helps them to make better. That's what helps make them better. And then orthoses can work well, but often in conjunction with other treatments, such as exercise. And since I started using exercises with orthoses, I must admit I have had better outcomes. And exercises aren't just for the young and fit, so it's not, we don't have to think, well, I only ever see elderly patients over the age of 70, they're not going to do exercises. Because as you've seen from the slides that we've gone through, there's quite a few foot exercises that you can do just while you're sat down watching television or reading a book. And often they'll probably have a bigger benefit on the elderly population than they will on the younger. And don't forget the small muscles, they're often overlooked. We often forget the names of them. I think we also focus on sort of the bigger muscles because we know where they attach and where they insert from. And if a patient comes in with a pain in one area of the foot, we think about the bigger stuff, but we don't break down the layers and think about the smaller stuff under there as well. So I think top tip there is print off, be it the slides or photocopy your anatomy book with the 4 layers of the muscles in the feet, and have them handy in clinic or have them on the wall to show patients, but certainly don't overlook them. So there's some references which are too small to read on my screen, but again, if you watch it back afterwards, you can pause this page and look up the references.